be given by Dr. Leila Mohan. She will be talking on clinical and surgical implications of rectus muscle pulley, current concepts. Rectus muscle pulleys are another very interesting and challenging area, and she has a lot of extensive experience in motility disorders. Dr. Leela, please.
Thank you, sir. I'm sorry for my sound.
Yeah, you're having bad throat, yeah.
So, clinical and surgical implications of rectus muscle pulley, current concepts. So, the extraocular muscle and the connective tissue around it is much more complex than we traditionally accepted classic concepts. We know that even the extraocular muscle recti have compartmentalization into superior and inferior, the horizontal recti and medial and lateral, and they have their specific functions also. And DEMA has shown almost 3 decades ago by high resolution MRI, when the MRI came in, the dual insertion of extraocular muscle and pulleys, which are actively shifted by extraocular muscle orbital layers. This pulley hypothesis put forth by DEMA has been anatomically proven in cadaver studies later. Recognizing the role of muscle pulleys allows more precise surgical interventions and ensures better postoperative outcomes, minimizing the risk of complications. So the pulley concept, which is a revolution in the concept of orbital anatomy, ever after the demonstration of pulleys in the beginning of 21st century, there is a lot of controversy regarding its existence. And in 2002, DEMA has shown the constituents of the pulley consisting of collagen, elastin and smooth muscle fibers, and this has a dense musculofibroelastic constitution, 2 mm in length, histopathologically and immunohistochemistry proved. Surrounding the extraocular muscles in a sleeve-like manner just posterior to the T-nuts, and the surgical utilization of this pulley can be useful in incontinent strabismus. By Mason's trichrome staining, global and orbital layers have been demonstrated in, and there's an anatomy journal which has shown in 2024 the presence of these pulleys. Passive pulleys theorizes that extraocular muscle slides freely through the pulley sleeves, and active pulley hypothesizes that the orbital layer inserts in the pulley and moves them horizontally. This is by high resolution MRI, it has been shown the global layer attaching to the sclera on the eyeball and a small orbital layer which goes and gets attached to the connective tissue around it. And the pulley controls the extraocular muscle path and serves as the functional origin. And the orbital fibers actively help in the rotation of the eye. There are some calculations for the rotation, how much it happens. And MRI taken in the coronal plane just posterior to the equator has shown the clockwise and anti-clockwise rotation in the right and anti-clockwise in the left produces an A pattern, and vice versa, producing a V pattern. And these are mostly congenital or which is seen in long-standing strabismus. And Burton Kushner has shown that V pattern always, with inferior oblique overaction also, doesn't always collapse after inferior oblique recession. It may be due to the heterotopy of pulleys. And childhood onset pulley anomalies are sometimes seen by the orbital anomalies as in Crusen's, and acquired pulley defects has shown the sagging of the lateral, sagging of the eye because of the regeneration of the bands between lateral rectus and superior rectus. This is a V pattern exotropia, where there is pulley heterotopy seen in the MRI, and also on table we can see that the muscle is, the anterior part insertion is normal, but the posterior belly comes from below, and then in which case you may have to displace the muscle instead of doing the inferior oblique recession. So there is still not a very clear-cut clinical examination that it is an inferior oblique overaction or Pulley heterotopy. It can occur even in heterotopy, it can show an over-elevation in adduction. So acquired Pulley dysfunction, as we see in sagging eye syndrome here, there is a ruptured and absent band between the superior rectus and lateral rectus. And in these cases, some clues are the deep superior sulci, ptosis and orbital fat loss in old people where there is a esotropia for distance. So clinical assessment, facial inspection for any presence of orbital anomaly, compare the lateral and medial canthal positions. The palpebral fissure slant may give a clue as to the heterotopy and rotation of the eyeball, and look for orbital asymmetry. Look for versions and also 9-gaze PBCT in elevation and depression, which gives the pattern. And when to do an MRI in esotropia for distance only with suspected abduction limitation, MRI can confirm the presence of extortion. Large axial length also above normal may point to heterotopy. And often these displacements are seen on the table during intraoperatively. So surgical implications to restore normal Pulley location and function in heterotopy, minimize Pulley utilization can minimize trauma to muscle and sclera, and they are potentially reversible also. This is an upward displacement of lateral rectus in heterotopy where there is a Pulley extorsion. When on the table you can see as and when you hook, the muscle is coming from below upward, and you can do a displacement of the muscle upward to produce one muscle width or half muscle width according to how much is the V, and collapse this V pattern. So for want of time, I will go ahead. This is one place where Pulley can be, the muscle displacement can be done in a Pulley heterotopy. So medial rectus scleral fixation, that is Faden versus Pulley fixation. Pulley fixation versus retroequatorial myopic sclera. So this is a comparison of the Faden and the Pulley fixation, where the extensive dissection is not needed for Pulley fixation. It can be done either after recession or before recession. We can take the that what you are seeing is the Pulley. You need a good assistant to pull the eye well away from the muscle, so that you get a good bite from the sclera, from the Pulley. So this 5-year-old child presented with acquired esotropia, accommodative esotropia, repeated atrorefraction showed there is a near-distant disparity. Pulley posterior fixation requires a long, strong adjacent Pulley. So medial rectus is the best in giving good outcome, and inferior rectus and superior rectus not so much, and lateral rectus, of course, even Faden is not it doesn't give good results in fadening lateral recti. So this is after Pulley fixation. This child had no esotropia for near as well, and it maintained. He comes even now, and I have started reducing his accommodative hypermetropic correction. So he is fully corrected for distance also, no distance and near with glass. So pulleys are fundamental to ocular motility. Pulley fixation is effective in convergence excess type and small partially accommodative esotropia as well. And utilizing Pulley reduces the risk of scleral perforation and saves time as well.